Okay. Go ahead, Mark.
Welcome, everybody. Today's Lunch and Learn is brought to you by the Chicago Asthma Consortium. Today's topic will be shared decision making for better asthma management. Next slide. Today, I am the moderator for the day. I'm Mark Rubin. I am an asthma educator as well as pharmacist for the past 24 years, practicing in pulmonary, covering allergy, asthma, and COPD. I'm a member of the Professional Development Committee, which creates these Lunch and Learn programs. And I'm also a longtime member of Quad AI, serving on three committees, as well as American College of Chest Physicians, better known as CHEST. Next slide. So today's agenda, we're going to begin for the first 5 minutes an overview of the Chicago Asthma Consortium and information about our speaker for today, Dr. Kelsey Alvarez. And at the end will be a Q&A session, of which during the presentation, you may put in the chats any questions you have you'd like to be addressed. And at the very end, there will be an open discussion that Dr. Alvarez is looking forward to where people can actually speak to you directly. Next slide. So the Chicago Asthma Consortium, the mission is to improve the quality of life for those people with asthma through advocating for them, educating both the patient as well as supportive healthcare providers, and collaborating both with the medical community as well as public health professionals, government agencies, and business leaders to work together for improving the quality of life, which is the most important thing in living is your quality of life. So those with asthma, that's a day-to-day thing. And you can help us by becoming a member to make a greater impact. And now, important reminders, today's housekeeping. Your video and microphone should be off during the first half of the webinar and at the closing of the webinar. The chat feature is great. Please, all of you, introduce yourself and say hello to the other attendees. If you have any questions for the presenters I mentioned before, type them in and they'll be answered during the Q&A session at the end. Also, at the very end, there will be, both in the chat and posted, a webinar evaluation to have your thoughts about the subject and the presenter, and if there's things you'd like to see in the future. Next slide. Ways you can help. Please volunteer to be on a committee. The newest committee is Policy and Advocacy, which is setting standards within CAC itself and advocating to outside groups. But the Community Advisory Board is for those other organizations who want to reach out to us for our perspective, getting involved in community engagement, bring more people in, fundraising, membership, and of course, the Professional Development Committee, which is responsible for bringing you this program. Any questions about it, you can just contact the info at chicagoasthma.org. Next slide. If you're not a member yet, ways to join is the QR code or just email the executive director at chicagoasthma.org for more details. Next. And now I'm going to introduce today's speaker, Dr. Kelsey Alvarez. She is the medical director of Mobile Care Chicago. She is a double board certified physician in internal medicine and pediatrics and did a residency in both areas at University of Illinois. Her career has been defining a commitment to health equity, innovation, and collaborative team building, which is critical. As a medical director of mobile care, she strives to address systemic health disparities and provide accessible, high-quality asthma and allergy care to patients of all backgrounds. She also has a passion for medical education and currently serves as the co-director for Doctoring and Clinical Skills course at the University of Illinois College of Medicine. Welcome, Dr. Alvarez.
Thank you. All right, let me share my screen with you all. Thanks so much for having me. I'm excited to be here. I'm excited to be talking with you all about a topic that's very important to me, shared decision making in asthma. Hopefully, we can discuss what shared decision making is, how it applies to asthma, a little bit about the evidence that supports shared decision making in asthma outcomes. What are some of the barriers to using shared decision making in clinic visit settings? And then how can we apply some practical strategies as well as what tools we could utilize to invoke shared decision making in our patient encounters? All right. So why does shared decision making matter? For those of you who are here who are clinicians and providers, I want you to just think to yourself, have you ever developed a treatment plan, explained it to your patient, and then on follow-up found out that they never tried it? And where did you go from there? What happened? How did you investigate that and figure out, what went wrong? Where was, was it communication? Was it access problems? Whatever it may be, we're going to get into that in a little bit. But just kind of think about those scenarios. For anyone who is an asthma patient, I wanted you to think about, have you ever been given a treatment plan and not followed it? And why? And what was that conversation like with your provider? Um, what's important for shared decision making and asthma in particular is to know, asthma is a chronic disease. It requires long-term self-management. And adherence to your treatment plan, as well as trust with your provider, can really influence outcomes. We know that asthma care improves when patients and clinicians can partner in making those decisions. And that's why it is so important. Shared decision making is really about aligning evidence-based care with patient goals in order to not only increase adherence, but reduce exacerbations and build trust in that relationship. All right. Shared decision making, as I just mentioned, is this collaborative process. And it's really what lies kind of at the intersection of that evidence and your clinical expertise, as well as the patient and family's goals and preferences and what they want to see in their care. And then also, the contribution from biological, psychological, sociological context that might impact that patient's care. And it's really kind of looking at shifting from, what we might call a more paternalistic care into this collaborative partnership, where we have conversations and ongoing dialogue, mutual respect, and also a shared responsibility for asthma management. I think it's helpful to kind of compare and contrast a little bit shared decision making versus other decision making models, just so that we can really kind of grasp what this will look like in practice. I like this graphic here that was from the evaluation of clinical practice. And it just shows us a continuum here of, the physician deciding versus the patient deciding. And then the flow of information going from physician to patient versus the flow of information going from patient to physician. So you can see kind of in each of these quadrants what the different decision-making strategies would look like. So a demand-driven decision-making is really where, patient decides and the patient is really dictating that flow of information, versus kind of this opposite corner here, paternalistic decision-making, where the physician really is making the decision and the flow of information is coming from the physician directed to the patient. And you can see here, right in the middle, is where we have our shared decision making. The core components of that being information exchange, being pretty equal between both the provider and the patient. Being able to discuss options, explore a patient's goals and preferences, make a joint treatment decision, and then afterwards have follow-up and reassessment of that decision. There is some decent evidence for shared decision making in asthma. Unfortunately, like kind of those harder concrete goals are a little more difficult to study. There's not a whole lot of studies, and the studies are all done in various different ways. And so, there's a good Cochrane review on shared decision making in asthma that does show some association. So there is definitely link in shared decision making in asthma to improved medical adherence. There's some association with better asthma control and perhaps fewer ED visits, depending on the exact studies you're looking at. And then I think it's fairly intuitive to know that there's higher patient satisfaction when you're engaging the patient in their own care and decision making. And it really does increase trust in that relationship. All right, there's a couple different models of shared decision making that can kind of help us set a framework when we want to implement this in our clinical practice. So there's the three different ones we're going to kind of briefly review. They're all basically the same. It's just different ways of kind of getting at the meat of the strategy. So there's the three talk model. There's Gina's four domains of social of shared decision making framework, and then there's the share model. So some acronyms in there too. The three talk model, I think this is the easiest one to kind of like implement and remember, particularly when you're in the middle of a visit. And so it's really three talks. So there's three components. The first one is team talk. And this is where you want to kind of open the discussion, acknowledge that, hey, there is a decision here, and we should make this together, make this decision together. This is where you want to figure out what are the patient's goals. You want to agree on your agenda, set expectations for your discussion. So you might say something like, there are some options we should think about together. What matters most to you? And that's where you're kind of getting that team talk started. Then you move into the option talk. This is where, as a provider, you would provide information about each choice. You might compare different treatment alternatives using risk communication principles. You want to try and frame the risks and benefits both positively and negatively. So, for example, you might say something like, this side effect occurs in 1 out of 10 people. So 9 out of 10 people do not experience it. And that's helpful just to give patients context. You also want to, during the option talk, address the option of no treatment change. You can use decision aids here if there's one available, or something like an option grid to help kind of work through what the options are. And then you move into decision talk. And this is where you put the focus back on the patient. You ask, what do you want to do? Why is that what you would choose? Do you have any questions that might help you make this decision? Again, what is important to them? Are they trying to avoid medication side effects? Is it most important that they avoid costs? And how can you help them make that choice? This is Gina's framework. Again, kind of similar, but this is particularly targeted to asthma. And so the four domains here is reviewing the preferred medication. So what is the best option from the clinical evidence for symptom control and reduction of risk? And then what are the patient's characteristics and phenotype? Are there any factors that predict different risk or treatment response, such as does the patient smoke? Is there a certain history of exacerbations? Do they have eosinophilia? Do they have an elevated pheno? And how might that impact your decision making? What are your patient's views? What are their goals, beliefs, concerns about asthma and its treatment? And then any practical issues that might affect your choice, like inhaler availability, the technique that must be used, and whether or not the patient can perform it for inhalers, affordability, their likely adherence, and then potentially also considering environmental impact of which inhaler you might choose. This framework is embedded in the GINA management cycle, and so it's kind of like a process they recommend you use whenever you're going through deciding your treatment plan. And then there's the share framework. Again, similar steps here, just a different acronym share. So the first one, seeking your patient's participation, communicating, that there is a choice, and that you want them to engage in this process as well. The second step, help your patient explore and compare treatment options, discussing the benefits and harms. Then assess, that's where you assess your patient's values and preferences, what matters most to them. Um, and then step four is reach a decision with your patient where you decide together on the best option, arrange for a follow-up appointment, and then evaluate. So this is also really important that this does not end at, the decision in that clinic visit, that you want to support your patient so that the treatment decision they make has a positive impact. And then monitor, how does their disease respond to the choice that was made? How are they able to kind of adhere to the treatment plan that they chose? And then revisit if needed. All right. What are some of the barriers to shared decision making? And for those who are providers, you may feel this very acutely. So, provider barriers, oftentimes there's a perceived time constraint. So, in studies that they've done of shared decision making and what the barriers are, it was reported in 22 out of 38 studies that physician perceived barriers like time constraints was the single most important obstacle to being able to do this in a busy clinic setting. We also, as providers, tend to overestimate how well we're already doing with shared decision making. So we often believe that we're involving patients in decisions, while observational studies suggest that we are not actually doing as good of a job as we think we are. Um, Medical jargon can be a barrier as we're trying to involve patients in this decision-making process. If we're using language that is inaccessible to them, that makes it tough. Assumptions about adherence is another barrier, or like the perceived inability of patients to be able to participate in shared decision making, or perceiving that it's not applicable to this decision. So providers kind of thinking that this clinical situation only has a single right answer, and so therefore not incorporating shared decision making into that. Um, or just a lack of training as well. Patient barriers could be things like health literacy, beliefs and concerns about medications, for example, negative beliefs about controller medications, fear of steroid side effects, perception that asthma is episodic rather than chronic, any cost or access issues, stress and anxiety that can contribute to participation in shared decision making, language or cultural barriers, any previous negative experiences. And then, of course, there's the system level issues as well. Having short appointment durations, lack of integration into our workflow, and limited availability of decision aids. So, of course, to improve our shared decision making, provider training can be really helpful. Pre-visit patient participation or preparation is one option, although in reality, like whether or not that's feasible is another question. Um, Implementing some practical communication strategies, such as, using accessible language, making sure to have interpreters available, making sure to have your patient education materials available in various languages as well, and then decision aids when possible. Using a teach back is another great strategy to improve those communication skills. So after you've talked about something, having that patient teach it back to you to assess for their understanding is really helpful. And then, of course, demonstrations of inhaler techniques, using visual aids can help communication as well. Um, there are some tools available for asthma to help with decision aids that can be great to refer certain patients to. So I included a couple examples here. So from the ALA, there's a biologics decision tool that is free and available online. There's also this shared or this severe asthma decision tool, which I thought was really nice. goes through various questions that a patient may want to consider and also ask during their visit. And then it has this great worksheet for them to fill out too about the various options that are available to be discussed with their provider. Asthma Action Plan is also a shared decision-making tool. This is personalized. It should be done in a collaborative way with patients, tailored to, their trigger management with customized medication steps and personalized zones with actionable emergency steps. And this really helps in asthma self-management to be able to develop this plan and co-create it, with our patients. Have a quick case study. We are already low on time, so I'll breeze through it a little bit. But we have a 25-year-old who has uncontrolled moderate persistent asthma coming into clinic, currently prescribed a daily inhaled corticosteroid, but she often forgets to take it due to her busy work schedule with varying shift times. Today, her spirometry is worse than her baseline. Her ACT is 15, which is poorly controlled. ARQ is 4, also very poorly controlled, and she's been having to use her rescue inhaler daily. So if we were to use a shared decision-making model, there's several questions I would want to ask her about. Those questions can address a couple different areas. So assessing her goals and values, eliciting what might be the barriers to medications, reviewing potential treatment options, and reaching a collaborative decision. And here I just have some ideas of questions that you might ask to get at kind of each of these components. Um, what is most important for you in terms of your breathing? Is it, being able to sleep through the night? Is it being able to play in sports? Is it being able to keep up with your daily tasks? Knowing these things from your patient can help you kind of figure out where we need to target our treatment. And then how does she feel about her current asthma control? So we're telling her she's poorly controlled. What are her thoughts and feelings about that? Eliciting those medication barriers. So, oops, sorry, I got an accidental repeat here. But really just figuring out, is she having any difficulty accessing her medications? Are there financial barriers? Are there problems at the pharmacy? Is she having difficulty, we learned from this case that she's having difficulty remembering to take it just because her day is kind of inconsistent. And so really kind of diving deeper into that and figuring out how we can help her address those barriers. And then reviewing her various treatment options. So, how would she feel about trying a different inhaler? Maybe smart therapy would be a great plan for her. Um, what questions does she have after we talk about various different treatment options? And exploring how, after we reach that collaborative decision, how confident is she that we can make this new plan work? You can have her rate her how she's feeling about starting the new treatment, and asking her what might work best for her lifestyle after we go over the available options. So we know implementing shared decision making can improve adherence, hopefully improve asthma control, and improves patient satisfaction by incorporating both the evidence, a patient's preferences, as well as those external factors that affect their care. And I would like to open it up for questions.
There's a question in the chat. It is, do medical students learn shared decision-making skill in medical school?
That is a great question. And I would say it is variable. When I was in medical school, I don't think so, at least not formally. Um, currently, like where I teach, yes, it is a component in the curriculum, incorporated kind of in your simulation experiences. Um, but I don't know if it is kind of like widely or universally applied. Thanks, Felicia. Any other questions? I see too that Mark has in the chat that teach back is really critical for inhaler device training. Totally agree about that. Not just the how, but also the why. And I think that's really important. The why behind each step of how you should take your inhaler um, is really helpful just for patients to always remember to do it that way. If it feels arbitrary, it's really difficult to make sure that it sticks. But if you can remember the why, it's a lot easier.
Also, Dr. Alvarez, Mark here. One thing I think is critical is patient education. And there are multiple sites, is like the Asthma and Allergy Network, but also American Academy of Allergy, Asthma, Immunology, and the American College of Allergy, Asthma, and Immunology have patient sections. You do not have to become a member if you are a patient. You log in, and they have breakdowns in every area that keep you up to date, like with seasonal allergies, that give you the knowledge to understand what's transpiring. There are multitudes of resources for patients, not internet, but actually medical organizations that provide accurate information that should be offered to the patients in the list so they can reach out and grow in their knowledge to take control of their lives versus being controlled by their asthma.
Absolutely. I love that.
There's a question from Bridget. How could you integrate community health workers in shared decision making?
Great question. I think this is like a really excellent area of opportunity for social workers, for community health workers to be incorporated. I think community health workers can be really great liaisons in shared decision making. They can help kind of translate clinical recommendations to patients and help them kind of tailor it to really match their needs. I think community health workers can also do like decision coaching for patients as well. Um, and kind of help them manage expectations, come up with um, uh, questions for providers and things like that. I think one of the other, I don't know if we mentioned it too much, but one of the other big barriers to shared decision making can be just like culture, both culture from like the provider sense of not being used to necessarily incorporating shared decision making, but also patients maybe not being comfortable or familiar with participating that much in their own care. And so the more we can kind of work together in a multidisciplinary way to make shared decision making the new norm, the better I think that would be.
There's a comment from Jessica. I don't know if you want to unmute yourself, Jessica, if you would like me to read your comment. Okay, I can read it. So it's from Jessica. It said, I work in the pediatric and will often rely on videos to help parents, child understand how to use inhaler nebulizer. Any recommended resources for patient-friendly language?
Yes, I love that. I think actually the ALA has a lot of really great resources. That's the ones I usually refer to when I like want to have patients watch a video. So that's where I would recommend. They also have a really nice like repository of patient facing materials that you can look at too. And they are great. They're patient appropriate language.
Also, the Allergy and Asthma Network. It's great. I'm not sure if they still have it. It used to be called Mothers of Asthmatics. So you've got the parenting skills dealing with the child. And it's really important when you've got a child with asthma that the parents also get very well educated instead of making misjudgments from lack of health training background, how to properly approach. Because it's also really critical for them to understand not just the disorder, but the environment of the home that can definitely affect how the child is improving or going downhill.
Absolutely. And then another question from Felicia. Do studies show that patients adhere to positive health behaviors like their meds, exercise, etc., when shared decision making is used? And the answer is yes. It varies a little bit from study to study, but generally adherence is much improved with shared decision making. And I think that makes sense. You know, when a patient has a say, has a choice in their treatment options or their treatment plan, that automatically gives you a lot more ownership in carrying through with that and sticking to it. Great. And if anybody wants to reach out, my contact information is still shared on the screen there. Feel free to reach out to me by email. I'd be happy to chat with you. Thanks, everyone.
Thank you so much, Dr. Alvarez. That was a wonderful presentation. And thank you all for attending today's Lunch and Learn.
And Rochelle, in closing, do you want to have the slide for connecting with CSC?
So feel free to stay connected with the CSC through our different social media platform. We love to stay connected with you and keep sharing all the wonderful information that are coming our way. We will take a pause for the summer with the Lunch and Learn, but we will resume in August with the series for the fall. So again, looking forward to see everyone, and you all have a wonderful day.
And be sure to fill out the questionnaire.